Good morning, everybody. At the outset, I would like to thank Arvind Eye Care System, Veena Ma'am, and Frederick sir for giving me this wonderful opportunity. Today I'll be talking about orthokeratology and red light therapy in myopia management. And yes, we are going beyond spectacles now. So I don't have any financial disclosures. This lecture will be a pretty basic lecture on the topic on Ortho-K and red light therapy. Uh, as we all know, and it has been stressed multiple times since morning, myopia is a global burden, and by the end of 2050, it states that half the population might be affected with myopia. So we do have different strategies for myopia control, and now I'll be talking about the optical intervention, one such of a kind, orthokeratology. So orthokeratology is the process of deliberately reshaping the anterior cornea by utilizing specialty contact lenses to temporarily and reversibly reduce refractive error after lens removal. So this lecture will be covering on what are the basics, what's the mechanism of action, what are the lens structures, what are the do's, don'ts, how do we select a patient, how do you evaluate, follow up, and what's its role in myopia control, and pros and cons with ortho-K. So when we take any routine rigid contact lens fitting, they have a few drawbacks. Reduction in corneal toricity, or the cornea tends to change its form from normal aspheric to a more spherical one. These are normally considered as undesirable side effects, but Ortho-K necessarily exploits this feature to eliminate refractive error. So orthokeratology also has various synonyms: vision shaping technology, corneal refractive technology, controlled keratoreformation, accelerated ortho-K, and contact lens corneal reshaping. So over the decades where we are, so initially this started in 1962 when Jessen brought the concept of using polymethyl methacrylate contact lens and devised a concept called orthofocus to see a better, clearer vision without any spectacles. So, future proceeding in 1970s, flat-fitting rigid contact lenses came into place, and in late 1980s, Lodge and Stoen were the first who developed the true reverse geometry rigid contact lenses, which we currently are talking about when we talk about ortho-K. And in future, with developments of high oxygen permeability rigid materials and computerized labs where we can prescribe and make customized contact lenses, and accurate topographers where we can take precise measurements, here we are with what we have today when it comes to ortho-K therapy. So ortho-K works on a principle of reverse geometry lens. So what do we mean by it? The conventional lens have the base curve, which is the steepest, whereas in the ortho-K, the reverse geometry lens, the second curve, that is the reverse curve, is the steepest. So it has four parts, as we can see. So the center one is the base curve, which is contributing to the refractive error. And the sides of it is the second part, that is the reverse curve, which is the steepest portion, which acts as a tear film reservoir and also acts as a negative pulling force for supplementing corneal reshaping by the base curve. And the third and the fourth curves are the alignment curve and the peripheral curve, which helps in the lens centration. And the peripheral edge fit is also important for easy debris clearance and tear circulation. So what happens to the cornea when a patient wears orthokeratology lens? So ortho-K lenses are usually worn overnight so that during the day they don't have to wear any lenses or glasses, and still they have a clear vision. So the shape of the cornea before the ortho-K lens, and after we fit the lens before sleeping, once the lens is fit on after sleeping, the cornea takes the shape of the ortho-K lens with the base curve and the reverse curve. And the center cornea becomes flatter, and this treats the myopic refractive error. So with the lens off throughout the day, they're able to see clearer. So squeeze film forces are what acts, and the center base curve gives a positive push force, which causes epithelial thinning in the central cornea, and the negative pull force from the reverse or the steepest curve causes mid-stromal and mid-epithelial thickening. So what are the indications of orthokeratology lenses? 4.5 diopters of myopia and 1.5 diopter of with the rule corneal toricity is the FDA approved one, but we can push up till -4 to -10 myopias also. A few studies have described about it, where they give partial or complete efficacy, where they use ortho-K in combination with refractive glasses. Coming to the contraindications, any previous failure with gas permeable contact lens wear, diseases of the cornea, conjunctiva, or the adnexa, anterior chamber inflammation, systemic diseases that affect the eye, for example, diabetes, any form of keratoconus, including the form first. Older patients who are already long-term contact lens wearers may not respond better to this kind of a reverse geometry lens, unrealistic patient expectations, and limbus to limbus astigmatism, because the base curve is what contributes to the refractive error correction. So a central corneal astigmatism is a much better suited candidates. Coming to the pros of Ortho-K, it is reversible and both eyes are altered at the same time. So there's no disruption of vision during the treatment and no pain compared with other laser vision correction treatment options. And it's a good option for children, especially 11 to 15-year-olds who are into sports, and they do require a clear vision during the day without any refractive error correction in the form of glasses. And it also has been published to slow down myopia progression. So coming to the cons, it's not a permanent solution. Patient may become a regular gas permeable contact lens wearer, which is not ideal. Amount of refractive error correctable by Ortho-K is limited, and there's always a potential for non-compliance. So how do we dispense? When a patient comes to us, these are the following steps which we follow. We give patient counseling, which is the first and the foremost important part of Ortho-K prescription, because safety and efficacy depends on how they use it and how they understand the method of use. Next comes the pre-fitting, the lens selection. Then we evaluate the patient and have regular follow-ups, and we decide on the endpoint. So I'm going to take you through a case and side by side discuss how we go about prescribing an Ortho-K lens. A 13-year-old male comes with a complaint of blurred vision in both the eyes, and they're already on a glass prescription of minus 2.25 diopter sphere for the right eye and minus 2 diopter sphere with the small cylinder for the left eye, and they want some glass-free options. So baseline, these are the baseline evaluations which we do before we prescribe an Ortho-K lens. The manifest refraction, especially cycloplegic mandatorily, a baseline topography, horizontal visible iris diameter and pupil diameters in dim and bright lit conditions, lit position, slit lamp biomicroscopy evaluation. So when it comes to the horizontal visible iris diameter, the Ortho-K lens should be able to at least cover 90% of the HVID, and pupil diameter at any point in time should be less than 6 millimeter for a good Ortho-K coverage. So baseline for this patient, the cycloflash was around minus 2.5 diopter sphere in both the eyes. The baseline axial length was documented. The horizontal visible iris diameter and the pupils were compatible with Ortho-K use. Then we went ahead with the lens trial. There are various methods which are available where we do trial and error lens fitting or an empirical method and choose the lens based on the manufacturer fitting nomogram. So the highlighted ones are the current available contact lenses in India, produced by the Paragon, Euclid, and the GP Specialist Systems, available in the form of Bausch and Lomb lenses and Paragon cornea refractive technology lenses. So we can choose this lens based on the manufacturer provided nomogram, and followed by the fitting assessment, trial and error. We do assess if the contact lens is proper fit or not. So the adequate fit pattern for an Ortho-K is described as a bullseye fluorescein pattern, where the center base curve is having a central touch of 4 to 5 millimeters, so does not take up the stain. The reverse curve, as I said, was a tear reservoir, so they'll have a pool of stain. So 1 to 2 millimeter wide peripheral zone of touch with 1 to 2 millimeter wide mid peripheral reservoir where they take up the stain, and then the next alignment curve does not take up the stain, followed by a small 1 millimeter peripheral zone which does take up the stain. So this is called the bullseye fluorescein pattern, which is an acceptable endpoint for myopia orthokeratology. Then we take to explain about how long it will take to act. So the refractive error correction comes approximately 10 to 14 days of regular overnight use of this orthokeratology lens, and advised time is at least 7 to 8 hours of use nightly. So in the initial 1-2 days, when we put an overnight Ortho-K lens, during the daytime after we remove the lens, the remodeling wouldn't have happened. So initially they might experience a blurring of vision. So we do ask them if they, how long after the removal of the contact lens, they do feel the blurring vision. So if it is more than 4 to 5 or 6 hours, we always ask them to have the refractive glasses during the transition period so that they don't have any blurring vision during the day. So they may need refractive correction during the day for the initial 1 to 2 week period. So follow-up timeline. After we start the Ortho-K, we have a day 1 to 2 week, 1 to 3 months, and every 6 months assessment thereafter. So in every assessment, we try to check the centration of the treatment. We do the corneal staining, and after 1 to 2 weeks, we start assessing the treatment efficacy. That is how long they are having a blur-free vision. If it consistently improves over 1 to 3 months, then we are okay to proceed them to call every 6 months, provided the lens is in a good condition. So every follow-up procedure, we follow an unaided visual acuity. We remove the Ortho-K lens and measure the visual acuity and a subjective refraction. It's better to do subjective rather than auto-refraction. Corneal topography, to see how the corneal topography has changed from the baseline. The central should be flat. Slit lamp examination with and without fluorescein dye. Lens quality assessment and axial length measurement to document progression. So the patient I was currently talking about, the 13-year-old male who came to us, we have a 25-month follow-up of the same patient. And over the 12-month and the 25-month follow-up, we do see that the axial length progression in the right and left eye has reduced by over 4 times. And the unaided visual acuity was 6 by 6 OU at the end of 25 months. So this is a small compilation of our in-house data over the past 2 to 3 years, where we prescribed Ortho-K lenses for children between 12 to 15 years predominantly, with a spherical equivalent range of minus 0.75 diopters to minus 4 diopters. And we do have a follow-up of around 6 months to 3 months range available with us. They showed a good response to axial length elongation, where they had around 33% slowdown, and on an average, and the maximum was highest was around 59%. The loss of follow-up was there. Around 5 to 6 children could not come back to us due to various logistic reasons. They had to discontinue the Ortho-K. That is one of the major drawback, because we have to stress that regular follow-up is important for a good safety and efficacy of this treatment. And 2 of them, they had to shift to DIMS and LDA due to logistic reasons. They are not from Chennai, so they had to come and they couldn't follow up, so we had to switch for myopia management. So keeping in mind with the pros, there are definitely adverse effects which we have to watch out for in our regular checkups. So it can range anywhere from anterior eye infection to corneal keratitis to overnight lens adherence. Corneal ion lines or fibrillary lines are very common, which is apparent within 2 weeks, and it's always reversible. There can always be an increase in the irregular astigmatism and induction of a lot of high order aberrations, decrease in contrast sensitivity. So this is kind of a decentered, inferiorly decentered lens, which is not acceptable. So other forms of Ortho-K, we have a toric orthokeratology and EDOF Ortho-K daywear prescribed by the SEED technology. So below tabular column shows the available lenses in India and what are the range of powers they do prescribe, they have availability for. Coming to myopia control with Ortho-K, already we have had a brief introduction to this by Dr. Jitendra Jitani sir, that combination therapies are working well. So these are few prominent studies with myopia control where they talk about orthokeratology in myopia and compare with conventional single vision glasses and also low dose atropine therapy. The few prominent trials are longitudinal orthokeratology research, the 2C study where they checked for toric Ortho-K lenses efficacy, and Romeo study, the retardation of myopia in orthokeratology study, where there was a 2-year randomized trial, and the myopia control study with Ortho-K lenses in Spain. So a few features of the Romeo study was that it was an RCT over a 2-year period where they had 78 children. The mean axial length elongation was 0.36 mm in the treatment group compared to the control group of 0.63 millimeters. And a meta-analysis also shows that there is always a difference of around 0.3 millimeters between controls and Ortho-K wearers. And 50% of reduction is generally documented with Ortho-K use for myopia control. And the main mechanism is again peripheral myopic defocus. So the drawbacks with Ortho-K is that the rebound is exactly not known because of higher dropout rates, and Ortho-K lenses are somewhat known to accelerate progression on stopping of the lens. The corneal infiltrates and infectious keratitis, especially in children, is not uncommon. So coming to the second part of the talk, the red light therapy. So at present, it's not available in India, and it's under a lot of scrutiny at this point. So what This is the first trial which has come out when we talk about low-level red light therapy for children. It was a multi-center randomized control trial, and the rationale for them to prescribe this treatment was to develop a side effect-free and accessible intervention for myopia for improving myopia control. So, what is repeated low-level red light therapy? A low-level red light therapy has been previously applied to wound healing and other peripheral nerve injury, especially in cases of diabetic retinopathy and myopia. So this approach exploits the potential of a low intensity near infrared light to enhance the activity of cytochrome C oxidase, which is important for mitochondrial work and related to downregulate the apoptosis and stress related processes, and in fact increase the bioavailability of nitric oxide, causing remodeling of tissues. So it main action stands in the choroidal end, where it increases the choroidal circulation, significantly increases the choroidal thickness, causes scleral remodeling to tamper because of targeting scleral hypoxia by improving mitochondrial oxidative mechanisms and reducing oxidative stress. So the only approved device is iRising red light device from China. It was incidentally found to stabilize axial length. In fact, it was approved initially for amblyopia treatment. It caused changes in choroidal thickness. So all published literature to date originates from China, but numerous studies are underway in Japan, Australia, and Spain. So this is the device. It's called MyProClear, where they advise or advocate a use of 3 minutes of red light therapy twice a day with 4 hours gap between the sessions for 5 days a week. And they say that in their multi-center study, they said that the axial length was reduced by 69.4% and axial progression, and spherical equivalent progression by 76.6%. So a few other following that study, they had come up with a 2-year post-trial follow-up study where the two groups, they had a red light therapy group versus the single vision group. So they had split them into 4 groups further at the end of 2 years, where they continued the single vision after the end of 1 year, or they switched between the therapies. That is, initially they had single vision and then took up the red light therapy, or first they were in the red light group and then switched to single vision therapy, or they continued to be in the red light therapy group. So as we can see in the tabulation, I'll just tell the key salient points that the highest progression control was seen in the group which was in the red light therapy for the 2 years, and the rebound effect was noted in the group which switched to single vision in the second year. So efficacy comparison was also done to low dose atropine, where they found red light therapy to be more effective than low dose atropine. But most common side effect with this therapy was found to be temporary after images, which mostly resolves within 6 minutes of cessation of the treatment. So the recommendation from their side is to do a fundus photography and OCT prior and during the therapy, along with home monitoring of visual acuity, and to also document the duration of after images. A recent United States studies also suggested that red light therapy exceeded the maximum permissible ANSI standard of light exposure, and it can pose a risk to the retina of photochemical and thermal damage. So at present, the sales of further devices are at halt in China, but available across several countries in Europe and Asia. Safety is still a concern. In conclusion, we need more studies on safety and efficacy beyond 2-year period with red light therapy, but it is a useful alternative. So what's up our sleeves? Every diopter of control improves quality of life. So we should start shifting from just single vision spectacles for the patients who need it. And fast changing arena with newer strategies are coming up. So we should be equipped with all of that. We have to update and improvise in our practice. And the key importance should be given to parent and children education and lifestyle modifications. So combination strategies are proving effective and should be taken up by us as well. Thank you for the opportunity, and I thank my team as well. They continue.